We're going to switch gears, and I'm going to turn this over to Luis Ostrowski-Zeitner, President-elect of the MSG ERC and at UT Houston.
We're in the final lap here. We have two very interesting posters to highlight today. The first one is particularly important to me. This is one of our former fellows here at UT, currently an assistant professor at the University of Arizona in Tucson, and Dr. Al-Obaidi is going to feature a case of coccidioidomycosis in a patient with COVID-19.
Hi, thank you for inviting me. And thank you, Dr. Ostrowski, for inviting me here. So let me figure out how to share my screen. Okay. Are you able to see my screen?
Yes.
Yes, we can move.
Okay. Hi. So first of all, thanks again for inviting me. And here I'm presenting a case about pulmonary coccidioidomycosis in kidney transplant patient with COVID-19. I'm Mohanad Al-Obaidi. I'm a clinical assistant professor at University of Arizona and transplant ID physician in Banner University Medical Center. Here's my disclosure, nothing pertinent for this presentation otherwise. But a little bit background here. First, as we discussed earlier in this conference, patients with COVID-19 infection are at increased risk for invasive fungal infection. Several examples given during this today's talk. And recently, actually within last year, there were several cases of coccidioidomycosis associated with COVID-19 infection being reported. Here, I'm presenting a case of immunocompromised host, unlike the last cases being reported in the literature. And especially here is important because COVID-19 and immunocompromised host are at increased risk for fungal complication, and coccidioidomycosis especially has a high risk for complication. So timely diagnosis is critical. So I will go over the case. This is a 33-year-old diabetic man with post-disease donor kidney transplant, presented with acute hypoxic respiratory failure and was diagnosed with COVID-19 pneumonia. Main symptoms were of COVID-19 cough and shortness of breath, and you can see he had hypoxemia with white cell count was low with lymphocytopenia, and had acute kidney injury. Immunosuppression was included induction with antithymocyte and maintenance therapy with mycophenolate, tacrolimus, and prednisone. However, the mycophenolate was switched to everolimus shortly before the presentation and was stopped because of COVID-19. And his home post-transplant antimicrobial prophylaxis included valacyclovir, atiroquois, and fluconazole. And our institute, we use fluconazole for coccidioidomycosis post-transplant prophylaxis for at least 12 months. His pre-transplant coccidioidomycosis serology and history did not include any positive like serology or history of cocci. And so as the donor, who was originally from Arizona, did not have documented coccidioidomycosis or serology. So during this hospitalization, during his COVID-19 hospitalization, he had to readmitted 3 times. So the first time he was treated with remdesivir and dexamethasone shortly and was discharged on his home antifungal therapy. And however, in 10 days, he was readmitted and he was having worsening shortness of breath. And you can see his CT chest here showing a worsening of his pneumonia, although we don't have a baseline one from previous admission. And he was treated with isobutanol and more steroids and antimicrobial. However, he had some improvement of symptoms and he was discharged. Unfortunately, in 3 days after discharge, he was readmitted again and required intubation. And that time, which is day 37 from initial diagnosis, he had a bronchial alveolar lavage, which was negative for fungus culture, as well as galactomannan. Despite that, he was on isobutanol, restarted from fluconazole at home. And you can see his CT chest is significantly worse. His serum beta-D-glucan and coccidioides serology, which is commercial test, were negative on several occasions, and the last one was on day 59. On day 46, he has a tracheal aspirate, which sent for fungus culture, and SAWS on day 61. It took 2 weeks for it to grow and showed coccidioides species. And on day 62, coccidioides antibody was sent to another lab, Mira Vista laboratory, which showed that it was very positive, despite the commercial test that we use in-house was negative. During that time, he was completely on isobutanol only, and we were interested to check the level, and it came back of 0.7 microgram per ml. Therefore, when you have a new diagnosis of coccidioidomycosis, we started him on liposomal amphotericin B, and we switched his isobutanol to voriconazole with therapeutic drug monitoring to keep a level at least of 1, because the patient had issues with transaminitis. And we have to increase the dose from 200 milligram twice a day to 250 milligram twice a day. However, because of complexity of the patient, we continued liposomal amphotericin B for 60 days. He continued to improve, and he was discharged after 2 months from the hospital. And he was on initial on tracheostomy and on supplement oxygen. On day 170, he slowly recovered, and he's off oxygen, and the tracheostomy was removed. He was switched to fluconazole because of continuous issues with transaminitis and voriconazole. And on day 239, after COVID, he repeated cocci serology. IgM was positive, but that's a commercial test, and IgG continued to be negative, and patient continued to feel great. So here I just wanted to discuss a few cases being reported in the literature resemble our case, but they're all immunocompetent patient. As Dr. Thompson, G.R. Thompson, showed in this case, which is the first one, is 23-year-old male, Navy, African-American male, who had COVID-19 in San Joaquin Valley, California. And after that, he moved to Guam, and after 30 days, he developed disseminated infection. Main risk factor was being African-American race, but no history of immunosuppression. But the patient was reported to be alive, and he received adequate treatment. The other patient was a 67-year-old from southwestern USA, and also had COVID-19, and but did not receive any immunosuppression or hospitalized, and was shown to have pulmonary nodules and chest wall lesions, which showed to be positive for coccidioidomycosis. Same thing, the patient was diagnosed and received fluconazole and reported to be alive. The third case in the literature was published from West Texas, actually, about patient with severe COVID-19 was with uncontrolled diabetes, required high-dose steroids. Unfortunately, the patient continued to worsen, and the last few days of his life was diagnosed with coccidioides posthidaceae. However, there is no mention about treatment because of delay in diagnosis. And the fourth case was a 65-year-old guy from Mexico, was admitted in hospital in Los Angeles with also severe COVID-19. And he was mainly being worked up for tuberculosis, and seems to be at some point, finally the team found that he had pulmonary coccidioidomycosis after he developed skin lesions. And liposomal amphotericin B was later on started. However, the patient was reported to be deceased. And the last two cases are a little bit different. Well, fifth case was 48-year-old Hispanic female from Bakersfield who treated for COVID-19 and found to have multiple nodules during her hospitalization. And main risk factor steroids. And patient was diagnosed early and was treated, and according to the report, was reported to be alive. And the last patient, as shown in earlier in our the talks, this is a patient, actually, he had history of coccidioidomycosis, and he's from Kern County, and was not on treatment, but after COVID-19, they noticed that his pulmonary nodules started cavitating and get worsened. However, there's no report about him being treated, even with that progression, and patient was reported to be alive. So overall, all these cases mentioned of immunocompetent patient with COVID-19, some of them are after COVID-19 or as a co-infection presentation. And the main issue here we have, even in Arizona, like the time to diagnosis is very important. For coccidioidomycosis serology test, most of the time we have lower sensitivity, especially in the early course of the disease. But in immunocompromised host, we tend to have like sometimes patient with delayed antibody production. Miravista antigen or galactomannan antigen and beta-D-glucan were helpful in severe cases and cases of disseminated disease. However, they are not helpful for localized infection. Also, we showed that combination of these testing, and as we showed in our previous ID week presentation, that we can increase the yield and sensitivity of the test. And recently, Miravista developed coccidioidomycosis enzyme immunoassay antibody test showed to have higher sensitivity, mainly in the immunocompetent patient, possibly in the immunocompromised patient, as shown here in our case. So coccidioidomycosis should be, an immunocompromised host should have a proper antifungal therapy be started as soon as possible. And this is based on epidemiology and risk factors. Mainly the treatment for coccidioidomycosis is azole therapy and liposomal amphotericin B. And with azole therapy, it's recommended to check levels. Although hydroxyfluconazole was shown to have activity against coccidioidomycosis in previous studies, it's still not known what's the proper therapeutic drug monitoring or if there's any guidelines about monitoring hydroxyfluconazole drug level. So overall, in conclusion, in cases of patients who present with COVID-19 or immunocompromised patient with COVID-19 in general, we should suspect coccidioidomycosis whenever the epidemiology fit. And we should think about treating the patient early on in the presentation. And the immunosuppressed patient, the serological test can be of low yield and vary between assays. And if it's suspected, we need to start treatment as soon as possible. And here we presented a case of possible isobutanol breakthrough coccidioidomycosis, and it's unknown if the isobutanol therapeutic drug level is the cause, or the immunosuppressed host, a high immunosuppression case, or it's related to other factors. And I would like to thank you all for listening to my presentation, and here are some of my references. And if you have any questions, let me know. Thank you.
Thank you very much, Dr. Al-Obaidi. Very interesting case, which clearly underscores the diagnostic issues we still have with cocci, even with serologic diagnostics, and of course, pitfalls with drug monitoring and breakthrough infections.